Virtual Unit Peer Leader Annual Training, developed in consultation with earlymobility.com. This module is part of a bundle of modules designed to help you with your training for unit peer leader training or for training of your peers on your units. The modules include what it means to be a unit peer leader, roles and responsibilities of being a unit peer leader, mobility screening, how to perform and use the VA mobility screening and solutions tool, building mobility into daily care, how safe early continuous mobility or SECM can actually save you time throughout the day, equipment review, lifts and slings, key considerations for purchasing equipment fares and sustainability of your program, crucial conversations, understanding and overcoming conflict and resistance to improve compliance in your program, and how to be the most effective educator that you can be to get the most out of your training and education. This module is on building mobility into daily care, how safe, early, and continuous mobility can actually save you time throughout your day. A disclaimer, earlymobility.com does not endorse any one product or product vendor and does not sell any SPHM technology. The videos used for these modules are purely representative of the types of SPHM assistive technologies available. There are many versions of all the assistive technologies in the videos. Check with your SPHM program manager to determine the models that you have in your facility. We're going to meet our interdisciplinary team before we get into the daily mobility throughout the course of care. And first, we're going to meet our occupational therapist, Amanda Levine, who's a safe patient handling mobility coordinator at McLaren Healthcare in Michigan.
I'm an occupational therapist. I've been an occupational therapist for about 17, almost 18 years now. I've worked in a number of different settings. I worked in outpatient, I worked in inpatient rehab, home care. Most of my career though has been in the acute care setting. And within acute care, I started as a floor OT, spent a lot of time in the ICU, critical care, neurointensive care units, as well as I've been in management. So I've had kind of a nice overview. Sure. So currently I'm working as a floor OT who serves the ICU, as well as I'm our coordinator for our safe patient handling program at the hospital at Mercant.
And let's meet Dr. Patel, our internist and hospitalist with Midtown Inpatient Medicine in Denver, Colorado.
I am an internal medicine trained hospitalist. I have been a hospitalist for about going on 8 years after residency. I work with Midtown Inpatient Medicine, which is a hospitalist group in Denver, and we work with SCL hospitals. Inpatient acute medical care is where my passion lies. You know, you work with patients and families at their most vulnerable. You get to see them improve, you know, day by day. Over the years, as I've been doing this, you know, mobility was initially a curiosity. As I became more involved with various hospitalist-driven metrics, it became more of, you know, an active reality, no pun intended. In my mind, as a hospitalist, we're at the bedside. We see the patients throughout their continuum of care. So we play an integral part in terms of advocating mobility, bringing it to everyone's attention, but also, you know, it should become our day-to-day workflow.
And let's hear from our physical therapist, Dr. Jamie Haynes.
My name is Jamie Haynes, and I currently teach at Central Michigan University in the Doctor of Physical Therapy program. I've been here at this position for 5 years, but I've been in physical therapy education for almost 15. And my role, I'm an assistant professor, and I'm a board certified neurologic specialist through the American Board of Physical Therapies. So that's pretty much my role. I teach in the neurologic interventions course here at Central. I do a lot of community outreach with people with neurologic conditions, and have begun to integrate, this will be my 5th year integrating safe patient handling content and equipment into our curriculum here.
And our CNA, Ronnie Turner.
My name is Ronnie Turner. I started working as an aide in 92. in a small nursing home in Estes Park, Colorado. From there, I started to do more like a travel aid up and down the Front Range here in Colorado. And after that, I decided, well, yeah, I needed a home. So I applied at a hospital in Northern Colorado, and I've been there now for the last 25 years.
And we're going to hear from our patient, Chris Guan, who has a unique perspective because he's been both a patient and a physical therapy aide and a nurse's aide.
My name's Chris Guan. I'm retired physical therapy assistant and nursing assistant. And I spent 26 years working at the hospital with various things, cardiac cath, telemetry, x-ray. And before that, I was 4 years, I was a Navy Carman. I was a medic with the Marine Corps, and I was an EMT. And I worked with the Air Wing with the Marine Corps at the FMS Carman and an independent duty tech for a while.
And we're going to hear a little bit more later from Kaylee Dayton, who's a doctor of nursing. She's a nurse practitioner and host of Walking Home from the ICU podcast. So we're going to talk a little bit about why mobility matters. We know that immobility syndrome impacts all immobilized patients, whether they are in the ICU or whether they're in our med-surg unit or our post-acute care. We have ICU-acquired weakness, delirium, difficulty weaning from a ventilator, increased mortality, pressure injuries, long-term physical and cognitive impairments, as well as thrombolytic events, deep vein thrombosis, long-term circulatory problems. In our med-surg units, we have incontinence, pneumonia, pressure injuries, decreased functional ability, falls, DVTs, confusion, inability to discharge home, and prolonged stays. In our post-acute settings, we see prolonged weakness. We see difficulty resuming social and occupational roles. We see a lot of depression and anxiety, increased use of medication, relationship difficulties, decreased overall quality of life, and of course, we see falls. And these are all worsened and to an extent caused by immobility-related problems. We know that mobility is the only intervention to prevent and treat immobility. There is no pharmaceutical intervention for immobility syndrome. The gold standard of care in our ICUs is the ABCDEF bundle, where E stands for early mobility. A large multi-center trial of 15,000 patients and a systematic review in 2019 found overall improved mortality, improved quality of life, decreased days on the ventilator, decreased incidence of delirium, improved functional level at discharge, decreased length of stay, and they also found that more patients were discharged home instead of to institutionalized care after acute care when we get them up and move them, and we assess and manage their pain, and we involve their families, and we assess and treat for delirium. So we know that daily activities are how we build mobility in. Dosage related to mobility, we know that once a day is not enough if the patient is not getting up throughout the rest of the day. For non-exercise daily activity, an active change in position relative to gravity is necessary every 30 to 60 minutes. This was an article that I authored with Dr. Joan Vernikos from NASA, who did all of the bed rest, head down bed rest studies on immobility with healthy astronauts. We know that to preserve activities of daily living independently, we must actually perform the activities of daily living while we're in the hospital. We know that shorter bouts of activity are more effective throughout the day than just once a day if we're looking at homeostasis and normal regulation of function. Mobility must be the job of all caregivers across all care settings. So we're going to hear from our interdisciplinary team members about interdisciplinary daily mobility.
For somebody who lives independently, who does their ADLs themselves. I think we should encourage them to do as much as they can.
So from the physician perspective, as much as they can. From the physical therapist perspective.
The research shows, especially in ICU and acute care, that we need to get people up more often, and physical therapists can't be there more often. And so when we work as a team, the therapist is the one that's challenging that patient and is pushing the limits, is in really promoting recovery very specifically in that time frame. But we also need the nurses who are with that patient hours upon hours to reinforce that for us. And so if it's using equipment, if a patient can sit up at the edge of the bed, then they should be sitting up at the edge of the bed to take their medications or eating. If the patient can get into a chair, using the equipment to get into a chair to really follow through with the ADLs that they're going to be needing to do at home. And so, I think that conversation is really important. And we know that when patients have success on things that are important, like I really would like to brush my teeth today, I'd really like to sit up at the edge of the bed and eat, I'd like to groom myself, we know that releases dopamine, and that's great for the brain and for recovery. We know that doing things that are salient are important. And so physical therapy may do that, or OT might do that once during the day, but that's the opportunity that the nursing care has, is that continuing to reinforce saliency for enhancing recovery, because everything they do with those patients is important to the patient. And so I think that's another thing that maybe nurses don't realize, that little bout of reinforcement 4 or 5 times a day is so key in recovery.
Can you speak to how you build mobility into all the things that you do with your patient in a day?
I would say it's not a once a day task. With our heart patients, we move them 4 times a day. Everybody, because it's helping the circulation, it's helping breathing, it's helping a whole lot of things. So once a day, when I hear once a day, no, it's not once a day. It's as many times as you can do it.
And Ronnie, like I said, is a CNA and understands the importance of his role in getting patients up frequently throughout the day. So what are some of the barriers that we come up against? Fear. Patients, they think it's going to hurt or it's going to be bad for them. Caregivers, I might harm my patient or I might get hurt when I get my patient up. Lack of protocols and standardized decision-making has shown to be a barrier. Lack of resources, equipment, staff, time. Lack of understanding about just how quickly ability to move independently is lost, where mobility is prioritized low throughout the daily care schedule. A lack of true interdisciplinary teamwork. It really does take all members of the team to have a successful, safe, early continuous mobility program. And a lack of standardized mobility terminology and understanding of roles across team members. This is one of the things that we can do to set a really strong foundation for our mobility program, is to help all caregivers understand how we can build mobility into what we're already doing for our patients on a daily basis during the course of care that we are providing anyway. There are many different protocols available for progressive mobility. This is one that was used with permission from the AACN website that basically looks at progressing the patient from most dependent to least dependent, or least independent to most independent. There's always a safety screening that's done for medical safety. We do a safety screening for physical safety using a mobility screening tool. We set our goals, and then we use the equipment to safely accomplish our goals for our patients. This is a great article that was put together by a team of 26 international experts on respiratory, cardiovascular, and neurological safety screening conditions for getting patients moving in bed as well as getting patients out of bed. And what I like about this article is they used a red light, yellow light, green light kind of an approach. A red stop sign says that the risk of harm may outweigh the benefit of the activity. A yellow triangle represents where extra caution is needed. And you have to weigh the risks and benefits and really talk to the medical team. A green circle means generally this is safe to do, in bed, out of bed. Excellent article if you're looking for safety criteria. Now we're going to hear from Dr. Kaylee Dayton on her perspective as a nurse and the importance of mobility, not just once a day, but many times throughout the day.
I'm Kaylee Dayton. I'm a nurse practitioner, but I worked as an ICU nurse for 7 years.
Excellent. And so you've had a role of nursing in early mobility programs across the care continuum or through ICU and acute care. Can you speak to us, Kaylee, about the role of nursing and what a nurse can bring to the table in an interdisciplinary team for promoting a culture of safe early continuous mobility?
When I started my RN career, I was in an ICU that mobilized almost every patient on a ventilator throughout the day, 3 times a day, unless there was a contraindication to mobility, which are few. And so it was just part of the culture to assume that I'm going to help get my patients to the chair and that they're likely going to walk, they're going to preserve their baseline throughout their time in the ICU, unless there really was an exceptional status change. And so as a nurse during day shift, when physical therapy showed up, I knew that I was going to be ready and get my patient up. We're going to walk through the halls. My patient's going to sit in the chair. I'm going to get my patient back to bed. And on night shift, there was no physical therapy. So it was just me, my respiratory therapist, and my CNA walking our patients on ventilators through the hall. And so we just understood that that was a big part of our job. And because everyone did it and everyone did it together, everyone was comfortable with that process. We all had that skill set, kind of like pronation is now after COVID. Everyone knows they jump in, they get it done, and you're done with it. And that's how mobility was. And because it was so frequent and with all patients, the safety just felt so much more assured, because patients were strong enough to basically get themselves out of bed, get themselves to the chair. Even during COVID with nurses, we were alone in the room with patients. They'd stand up, get themselves to the chair with a standby assist. So that it was just an assumed part of the role that I was going to keep patients as functional as possible, even though that they were critically ill. And then later when I went to a step down unit, as a travel nurse, I was in a different hospital system, different ICU culture, and I was receiving patients that were coming out of the ICU that did not have that kind of mobility throughout their time in the ICU. And it felt unsure, it felt dangerous. And I felt a big burden as a nurse to try to then get them ready to go home after they had not been mobilized. And that's when it became a lot more difficult, but I could feel a greater sense of urgency as a nurse to make that happen. Especially in the ICU, and I think for any part of acute care, your shifts fluctuate so much, your acuity with your patients fluctuates. There are certainly times, I know as a nurse, when I can't even leave my patient's room because they're actively crashing. I can understand that. For most shifts, for most normal workloads, you just have to integrate it into your normal part of the shift. I don't let my patients eat in bed. So if they want to eat, they have to get out of bed. They don't take meds in bed. If they're taking orally, they need to be up in a chair. So setting that standard and just encompassing that in the normal routine. It's part of my neuro exam to get them into bed. I trust evaluating for ability to follow commands, limb strength, things like that as I'm getting them up. As you integrate it into part of your process, getting them to the commode, it just becomes a routine, a rhythm. And when your entire team has that, you're supported in that as well. It's not just me alone as a nurse having to do this. I know when my CNA comes, they're going to be comfortable and prepared to do that as well.
So it sounds like having a culture and having that expectation is a big part of it. And I think many facilities, many nurses that we talk to struggle with feeling like they're kind of swimming alone in an ocean and they're trying to go in the opposite direction to everybody else. And that's really hard. And so I heard you say more than once that culture is such an important piece of this.
And it really impacts the timing and the time it takes to mobilize patients. In that awake and walking ICU, patients are intubated and they're up walking within hours afterwards. I've walked patients on a PEEP of 18 and 100%. You're just walking them throughout that time. So it does not take 5 people to get them up. It takes 1 person as a standby and then maybe even 3 people to walk them around the unit. That changes things. Whereas when we get patients from other facilities that have been sedated and immobilized, then we're trying to mobilize them. That's when it does take so much more time. It's greater risk. It's scarier. So I think preventing that scenario for most of our patients is the key to success.
Sure. And again, if I can just point out something I heard from you that I think just resonated, prevention saves you time, right? Because
Rehabilitation, not just rehabilitation, but if we focus on prehabilitation thinking, they're critically ill, they're at high risk of ICU acquired weakness. We know that we can reduce that by mobilizing them now. It's going to be easier, faster, quicker now than later. Mobility is one of my greatest tools to treat agitation. So for night shift, for example, I know that if I have my patient up in a chair until about 9 o'clock at night, I mobilize them, then I tuck them in for night. That is how I win a quiet night. But if I don't have the skills, or I'm not allowed, or I'm not even thinking about mobility, I'm much more likely to have an agitated patient throughout the night, or I'm much more likely to sedate them, or they're going to become harder to mobilize the next few nights that I have them. So I need that tool in order to treat delirium. If they get confused, agitated, they're sundowning, mobility is going to be one of my greatest tools to keep them safe and to keep it manageable for me. We all know what it's like to treat a delirious patient. It's a lot of work. So that's how I reduce my workload, is spending 10 minutes on mobilizing a patient and then having hours of peace. When we compare the workload, I don't have the hours calculated, but I think with sedation, there's a laundry list of things that we have to do. We have to run at least 2 sedatives, usually propofol, fentanyl, sometimes 3 sedatives going at a time. Depending on how fast the rate is, we're switching bags out, we're double checking with another nurse, we're wasting. Sometimes we're hanging a vasopressor to compensate for the sedation. That's a lot of in and out. You think about COVID, all the PPE that was going on. That's a lot of work just to keep those drips running, and then turning Q2, and then you get a pressure injury, and then you have to treat that. You have to chart restraints, then you have to deal with the delirium later. There's a lot of extra work that happens that we don't necessarily perceive as extra work because it's the norm. Whereas we exchange those efforts and a lot of times decrease the efforts when we prevent delirium, prevent ICU acquired weakness. A patient say calm, cooperative. You're not wrestling a patient. You're not having to haul them out of bed.
So very valuable message from Kaylee Dayton about saving time through mobility. Let's hear from Amanda, our OT, about how to overcome some of the family resistance and the fear that can happen related to family expectations.
This is too early. And so then you time out, we sit down and we have a conversation with education and involve the patient. And at our higher level patients, we'll say, do you want to get out of bed? And the majority of the time they say yes, they want to get out of bed and want to move. Their back gets sore, their hip gets sore, their shoulders, their neck. So they feel better getting out of bed.
Involve families, ask them to get involved, help get their loved ones up. They want to help. So let's hear now why safe patient handling matters. We've heard why mobility is so important. What about the importance of the safe patient handling technologies? We know that caregivers consistently rank in the highest industries most likely to get hurt at work. We know that there are many indirect costs of work-related musculoskeletal disorders, staff turnover, morale, recruitment, training of new staff, lost productivity, quality of care, falls, absenteeism from injuries, disruption in care, length of stay, decreased continuity of care, agency or replacement staffing, customer satisfaction, pressure ulcers, staff stress level, increased medical errors. The cost when we are tired or sore or fatigued is a lot more than just the cost to us and our families. Let's hear from Dr. Patel.
Early mobility is challenging because it requires the collaborative efforts of busy providers with different training, experience, patient responsibilities. So identifying these barriers has been the key in achieving success in this venue. So one big barrier is the fear that our patients will fall. Safe patient handling equipment is key because it allows our caregivers to maximize our patients' mobility while limiting that risk. So in our mobility pilot at SEL, we use walking slings and mobile lifts for patients with higher fall risk. And we also use stand aids to get patients moving sooner. So knowing what safe equipment we have, which will mitigate injury to the patient and staff, is a great educational resource in terms of bringing safe mobility awareness to all.
And from Dr. Haynes?
I think it's helping each other problem solve as a team. Why, looking at the why are there still barriers? How can we fix those? But I can tell you that safe patient handling has changed my practice. From a physical therapy standpoint, from teaching others, and that the immense positive that can come out of getting that very difficult to move patient or that critically ill patient to move again, there's nothing like it. There's nothing like it. And we can do so much more than what we could even 20 years ago. So I just hope people will consider that the joy that this can bring to really make a difference in someone's lives sooner, quicker, and then with less injury to any of us.
And from our CNA, Ronnie?
I think the equipment gives you so much more, and then with some of these patients without the equipment, I mean, you really can't do much.
And another perspective that is so interesting from Dr. Patel.
If there are some watching today who are more inclined to keep their patient in bed because they're worried about harm to the patient by getting up, what would you say about that decision?
I would say it may be a disservice, an unintentional disservice. You may be surprised how easy and safe it is to use this equipment. And if you need resources, to reach out to the appropriate supervisors to receive education on using this equipment, because that may be a disservice to the patient in the long run.
So we want to work together to achieve safe mobility for all. And in the next part of this module, we're going to look at what this looks like in the course of daily care.
Sometimes I hear people saying that mobility is therapy's job, that it's not really nurses' job to do mobility. What would you say to those people?
I would say it's everybody's job. We cannot wait for therapists to move people. It's part of your job too. We are a team, and unless there's something really, really bad with the patient and you feel as though you need to wait for therapy, then do so. But 99% of the time, we can do it.
I see it as my role when I round on the patient at the bedside, one, to assess what their baseline functional condition has been, two, to assess how far they are from what their baseline is, and three, what we can do to improve upon that. And when I say we, I mean the interdisciplinary team, including the patient and their families. Bringing awareness to them that laying in bed leads to a 1 to 5% daily loss of muscle strength. Laying in bed every day leads to all these other factors, such as delirium, hospital-acquired infections, and also knowing that we as a team are committed to improving their physical strength while we're working on their medical conditions. So I see my role as telling them it is okay to move. In fact, it's better for you to move. And here are the resources we have in place to help you do that safely.
We also need a common language about mobility across care team members. And in one of the other modules, the Mobility Solutions and Screening Tool, we get into this in a lot more detail. but we're going to look just very briefly at the different tools that are available and their different functions. So we have mobility screens. This tells us what activity the patient needs help with right now. What can they do? What can they not do right now? Doesn't tell us why. It just tells us how to keep them safe and what tools I need to use to achieve their mobility goals. Diagnostic tools tell us what's wrong with the patient, why they can't move independently. Evaluation tells us how I decide which treatments will be most effective. Assessments, initial and daily, help us understand how the patient is tolerating or responding to the treatment. How well am I preventing complications of hospitalization? Are they improving over time? Outcomes tools help us understand if our treatment is working. Is there a change from baseline? Are they getting better or worse? And then discharge planning tools help us understand when the patient's ready to go home, what kind of resources they need. Do they need additional treatment outside of the hospital? And then we have facility and national outcomes, which looks at how well we are mobilizing and measuring our patient benefits as a facility compared to national benchmarks. The focus today is going to be looking at mobility levels and what kind of activities and equipment can we use to build mobility into daily care, utilizing the equipment solutions that we have with our safe patient handling programs. If doing that screen, if that were part of the practice of every caregiver, every therapist, every nurse, every CNA, do you think that would have impacted your mobility when you were in the acute care hospital, when you were in the nursing home? What difference do you think it would have made?
Absolutely. For one thing, it shows to me that the person that I'm working with, I has confidence in me, but I have confidence in them, because if they're doing the screening, they're actually interested in what are my limitations. They're watching what I'm doing. And you notice, what did that take? 30 seconds? That didn't take any time at all.
That's
And one of the things caregivers, I don't have time to do that. And the time it took you to say I didn't have time to do that, you could have done that.
Common mobility and safe patient handling language is needed for consistency across all disciplines, including the patient and their families. So how do we build mobility into our daily plan of care? First, we identify the mobility or activity goal. Second, we do the mobility screen to determine how much they need help with. And third, we select the appropriate device to replace manual assistance to help them perform their activities safely. So we have a mobility bridging tool that we use and explain more in the mobility solutions and screening tool module. But we start by looking at the patient's mobility goal. And this is across the top of the bridge. Once we know their goal, then we go down and we do our mobility screen and we determine how much help do they need with that goal. So the first step is to see which column we're in. Let's say our goal is standing. Then we look and see what our mobility screen tells us. And in this case, it would be level 2, moderate assistance. Use the powered devices to help you stand. And this can be applied to any mobility goal, any mobility level. We know that we can build mobility safely into daily care throughout many activities. Dr. Haynes talked about vital signs, having the patient sit up if possible. Heels for meals. Meals provide 3 opportunities a day to sit up and mobilize. Anti-gravity. Let the patient do as much as they can for themselves. Toileting presents another 4 to 8 times per day to sit up, stand up, transfer onto the commode, or walk to the bathroom. We also know activities of daily living, eating meals, brushing teeth, getting dressed, washing, shaving, combing our hair. Your decision to get the patient up or leave them in bed today can impact them as long as 2 years from now. And we know that many things are impacted: quality of life, cognitive and physical abilities, ability to work, relationships. what we do today makes a difference for a really long time for our patients, sometimes permanently. So let's take a look at building mobility in enduring vital signs and med passes. We'll first be looking at the mobility screen. In this scenario, you see the nurse's aide asking the patient to sit up. You see that she's having him reach for the bed rail by himself. That's engaging his brain. So often we do that for the patient. This is an easy thing that doesn't add to the nursing time, but it is important in patient participation. So our patient here failed to be able to sit up by himself. He's level 1 mobility, needs help to sit up. So when we use our screening tool, our bridging tool, let's say his goal is standing and transferring. His mobility level down the left side, he needs help to sit. So we know we need powered devices to sit or stand him up. If his goal is standing, we can use the tilt bed. We can use a powered ceiling lift or floor-based lift to stand up. So what might this look like for Jim's vital signs? In this scenario, you see him using the bed. If your bed goes into chair position, have the patient sit forward for their vital signs. So as the nurse comes up and evaluates him, has him do a few exercises while she's sitting the bed up, stretching his legs, you see her having him pull his shoulders away from the back of the bed, resting his hands on his knees. This is mobility. He's holding his core up. This is going to strengthen him. So if your bed goes into chair position, use this to have your patient perform mobility. What about meals? Again, you'll see the caregiver here putting the chair in bed position. One step better, she had the patient do it himself. She'll bring the tray in, but again, she'll have him sit forward, use his arms. She won't allow him to sit with his back resting on the bed to have his meals. Now, even better would be to get out of bed or sit on the edge of the bed. But if that's not possible, even having your patient sit unsupported is better than having them laying recumbent without using any muscles eating their meals. We're going to look at what active participation looks like for Jim, even when we're using a sling. So we've got two nurses or nurses' aides inserting a sling, but you saw that he rolled himself over. Do not passively roll the patient if they're capable of doing it themselves. When he comes back over to the other side, you'll see him reaching, holding on to the bed rail. If he can help pull the sling out, have him help. If he's able to reach the straps or the loops of the sling onto the hanger bar, you'll see here the nurses are encouraging him to participate. This will not only keep his mind busy and give his brain something to do, but it will also make him less fearful of the lift. When you actively engage your patients, they will fear less. You see him here in the lift walking his feet around. This is mobility. We don't have to always be walking up the hallway. All of these activities can be considered mobility. What about getting out of bed for meals? You'll see again, the patient has his own hand control. If the patient is cognitively able and is following directions and is not combative, why not give them the control of the motor? He is able to lift himself up. We can move him over, but then he can lower himself down. You can even include a little bit of sensory integration. Hey, Jim, tell me when you feel your bottom hit the floor. Find the up button, find the down button, and stop when you feel the chair under your bottom. When we're bathing the patient, you'll see here, putting a friction reducing sheet underneath him. He rolled himself. You have to bathe him anyway, So why not have him actively participate? Do you see they're having him pull his own friction reducer out from behind him? Now that he's on this, he can move himself to the edge of the bed. This is mobility. You don't always need to be walking up the hall. I know I'm being repetitive, but we must remember when we can have the patient actively participate, this is all part of building mobility into daily care. And it's how we do it without adding tasks. If we have to bathe the patient anyway, why not sit him up into a chair position? Why not give him his own washcloth and have him wash the parts of his body that he can reach for himself? When he's on this slide sheet, he can shimmy his body side to side. He can work all the muscles of his body, even in a chair position in the bed. Grooming, same thing. Have him perform it independently. Getting him up to a commode, you'll see here a different kind of lift. The earlier one we used a ceiling lift, but you can do the same thing with a floor-based lift. He's raising himself. As the caregivers, you're going to make sure that everything is properly attached. It's your job to make sure that the safety is taken care of. But again, you see him walking his feet to the side, lowering himself down onto the commode. Toileting in standing. If you've got a bed that goes into a partial tilt or you've got a full standing bed, have the patient stand up. You saw this earlier with in the module with the mobility solutions and screening tool with a bariatric patient standing up even when they're mobility level 1, because the bed is doing the lifting. But if the patient can participate and you can stand him up and give him a urinal, he will void his bladder better, his lungs will work better, his bowel and bladder will be more effective, he's getting weight bearing on his feet. If you've got a bed that goes into a partial or a full standing position, use that feature during your activities of daily living. We can also do exercises in this position, whether it's chair position of the bed, whether it's a partial tilt, or whether it's a full tilt. When you have a bed with a footboard on it, you can have the patient marching, you can have them doing little squats, you can have them lifting their arms up, and you'll see him doing some of these activities here. There's lots that you can do to strengthen the patient. As a nurse, family can help. Get them involved when they come in to visit. Obviously, you're in charge of the safety, but there's lots of things that you can do to build mobility in to what you're already doing with the patient. And like Kaylee Dayton said in her interview, by mobilizing the patient, they're going to get tired, they're going to sleep better, they'll have less agitation, less anxiety, less pain. What about repositioning? So you can have them actively participate with repositioning, whether you're using a friction reducing device. As you saw earlier, the patient can help with inserting that repositioning device. And once you get good at these tools, they really don't take very long at all. And in fact, many of the time studies that we've done with these tools show that it takes less time once you have learned them. There is a learning curve, but it takes less time to put in one of these tools and have the patient move themselves than it takes to wait for another person to come and help you. So once this slide sheet is in, you'll see here that they're having the patient bend his knees up and he can push himself up in bed. He can turn himself over. This is strengthening his legs, and it eliminates the lift and the boost that the nurses have to do. You have to reposition him anyway. So build mobility into what you're already doing for him. If you have to turn him to check his skin, to bathe him, to wash him, to change the bed linens, put a slide sheet under and have the patient help you. It will actually save your time, it will save your backs, and it will help that patient build mobility into their care. You can do the same thing with a repositioning sling. Even when we have a full body repositioning sling under the patient, you'll see here, but they can bend the patient's knees up and have him walk himself up and down the bed. You're already using the sling. All you're doing is giving him a little opportunity to use his own muscles, his own brain in something you're already doing. So now let's meet Chris again, and let's look at Chris's mobility screen. We always want to know how much they can do, what their mobility goal is, and where we need equipment. Chris can sit up, he can stretch his legs. Let's see if he can stand up by himself. We're going to check this before we assume he needs help. Chris was not able to get himself up, so we know that he is a level 3P, or powered moderate assistance, needs help to stand. So let's look at our bridging document. We're going to look at our goals. Let's assume our goal today for Chris is walking. His mobility level is a 3P. We know we're going to need powered devices, either a powered stand aid with a removable foot plate, or some kind of walking harness to get Chris up and achieve his mobility goals safely for him and safely for us. So how might we do vital signs for Chris? He can sit up by himself. He doesn't need any equipment. To use equipment with Chris would be undoing his mobility and making him more dependent. So he does not need any equipment to sit up over the side and do his vital signs. And that's an opportunity to build mobility in throughout the day. What about meals? The best position for Chris to eat his meals is up in a chair. We know he needs a standing powered device to help him stand because he's a 3P. We can either use a powered standing and raising aid, which we're going to see here, or you can use a ceiling lift with a walking harness. Either way, you're using power and you're having him participate. So just because you're using a powered device doesn't mean your patient is passive. So even if your patient can partially stand, have him work. You see here, he's not just hanging back. The staff are encouraging him to stand. So even if a patient can almost stand by themselves, but not fully, you use your power for safety and you actively encourage your patient to participate. Things like beat the lift, get your belly to the bar. These are phrases you can use. Now you want to always check with your manufacturer instructions that it's okay to take the tension off the sling, that if you're using a sling and lift combination, that you don't need the tension of the patient leaning back. You'll see here that the nurses are going to ask Chris to bring his hands back down to the bed, to the chair as soon as he can, to lower himself down as he would with a regular chair. This is mobility. This is building mobility in to daily care for a patient who's level 2 or 3P. You'll see the nurses have the patient actively help take the sling off the lift. Remember what we said with Jim, actively engaging the patient helps them feel empowered, helps them feel like they're part of the solution, and it reduces fear in the lifts. Toileting and grooming. Again, we're seeing here that the patient is helping to pulling himself up to get the sling attached to the lift. He's activating when and where he can. If he falls or he loses balance or he is unable to maintain it, he is safe. And look how much lifting the nurses are doing. None. This, even with somebody who is Chris's size or even bigger. Chris is only about 350 pounds. In this one, he might be a little more. But a patient that's 700 pounds, 600 pounds, if you have the right equipment, you can do things safely, building mobility in with no risk to the patient or to the caregivers. In this scenario, we see Chris going to the sink to wash his own hands. In a sit to stand lift, you might have to do a sideways approach. In some of the non-powered stand aids, you can actually get to the sink facing front, or a ceiling lift with an ambulation harness, you can reach a sink or a toilet without the lift getting in the way. But there's ways that we can build mobility in. If you're not sure, work with your therapy team to help you understand how to do this without adding more care. This is all ADLs for Chris, just showing a different way of getting up, again with a ceiling lift. And you saw that the first part of the lift he needed help with, but when it comes to the rest of it, he can activate his own muscles. So once he's up, he can walk. But if Chris were to fall, what would that look like for Chris, and what would that look like for the nurses? When you use equipment, and again, you see some versions of the equipment here, but there's lots of others. Your models will work for this just as well. You saw Chris fall. No big deal when he's in an ambulation or a walking harness, right? He can just get up and keep going and go back to his bed or to the toilet or to the chair or whatever. Now let's meet Tim. Let's look first of all at doing the mobility screen. Can Tim sit up by himself? Can he shake your hand across midline? Absolutely. Can he stretch and point his legs? Let's have a look. He's got good strength on his right leg, good strength on his left leg. He's past level 2. Next step is, can he stand and can he maintain it for 5 seconds? Let's check and see what this looks like from sitting position. He can stretch and point. Yep. Stand up. When he goes to try and step and march, he loses balance. So Tim would be a 3N. Tim's goal is walking. His mobility level in this scenario was a 3N. When you saw him get up from a chair, he could stand with steadiness for 5 seconds, but he couldn't march and step safely and independently. For vital signs for Tim, we're probably still going to do it in sitting, but he can do some exercises in sitting. He can come forward. He certainly can hold his own thermometer. When we're getting him up to a chair, let's look at what it might look like for Tim to get up to the chair. This is another example of an ambulation harness or a walking sling. You'll see the patient participating again and helping with donning the sling. This again is mobility. Don't think about this as, oh my goodness, it takes too long to set it up. This is mobility. The patient is actively participating. He can lift his own legs to put the leg straps or adjust the leg straps. He can hold the straps up. He can help attach the loops onto the hanger bar. Remember, it is always your job as a caregiver to make sure those straps are properly seated in the hanger bar. And again, here, just because you have the harness on doesn't mean you need the power for the whole movement. In this position, Tim was able to help with some of the activity. We're using the walking harness for balance and fall arrest in case he loses balance. He's lowering himself into the chair. He stood himself up, but he has the harness on in case he needs it. For toileting, we're going to look at using a non-powered standing aid. Again, this is for Tim's safety. To get him to the toilet if he has urgency, we might leave the foot plate on or we might have it off. So often we would be quick to put those flaps down. We're going to have the patient put them down himself because that adds participation and mobility in. If Tim loses his balance or he gets tired, he can sit. His knees have got a blocking mechanism in front of him. We have to get the patient up to the toilet anyway. Let's build mobility into that activity. We saw toileting very differently for Jim, level 1, For Chris, level 2 or 3P. For Tim, level 3N. And obviously somebody who's a 4 or a 4A who's independent doesn't need to use the equipment. We hope that you're seeing that different pieces of equipment are appropriate for daily care for different mobility levels to accomplish the same goals. Again, you might choose to have Tim do 5 sit-to-stands, little mini squats, while he's on that non-powered stand aid before he sits down, with hands, without hands. This is also mobility. All of these things you've seen are ways that you can build mobility into your daily care. And often, once you get good at the equipment and you know your patient's mobility level, not only will it not add time, but it will actually save you time because your patients will stay functionally independent. They will recover faster and ultimately require less care. So Tim is washing his face in an ambulation harness, a walking sling. If he loses his balance, it's not a problem. He is safe. We talked earlier about the difference between a ceiling lift and a floor-based lift for getting to the sink. Ambulation for a patient who just has a little bit of unsteadiness. This is another low-tech device to help prevent falls if the patient is able to ambulate, but is at high risk for falls. You'll see here it's got a belt that goes around the front of his waist and a little, almost like a bicycle saddle that goes underneath his bottom, so that if he loses balance and falls, he is safe. But it gives him the freedom to move and the freedom for the caregiver to not have to worry if he loses balance because the device will catch him. So it takes the fear out of ambulation. In all these activities that we've seen from level 1 through level 3N, from sitting up goals to standing goals to walking goals for patients across all sizes and shapes, how much lifting have you seen the nurses' aides do? None. We allow the equipment to do the lifting. So in summary, mobility is extremely important and must be integrated throughout the day. Manually lifting and moving patients keeps caregivers consistently in the top 5 industries most at risk for a musculoskeletal injury. There are barriers, but these can be overcome with a team approach and use of equipment to keep everybody safe. Safe patient handling and mobility technology is how we build mobility into daily care. Using a screening tool standardizes decision-making and keeps everybody safe. And there are many ways, we hope you've seen many, many ways that you can build mobility into care that you're already doing anyway. Safe patient mobility is best for patients, best for staff, and is excellence in quality care. Congratulations, you have successfully completed the module on building in mobility. We thank Jim, Tim, Chris, Ronnie, Amanda, Dr. Patel, Dr. Haynes, and Kaylee Dayton for their contributions to today's session and on successfully building mobility into daily care. We thank Claudia Chabet and Riley Holek, the nurses who were gracious enough to be our actors for our nurses. And thank you for the care that you provide to all of your veterans every day. We hope that this module helped you get some ideas and strategies to save you time and achieve better outcomes for your veterans and less back pain, shoulder pain, and neck pain for yourself.